Thank you very much. I'm going to be covering standard and emerging treatments for metastatic castration-sensitive, non-metastatic castration-sensitive, which becomes oligometastatic castration-sensitive based upon leading-edge imaging technologies. Those are my disclosures. Just to review the nomenclature for advanced prostate cancer, in the past we used to call things biochemical relapse. We can now call that non-metastatic castration-sensitive prostate cancer, which over treatment with ADT becomes non-metastatic castration-resistant. Metastatic disease can be described as having low or high volume, and metastatic castration-sensitive disease can be characterized as either being pre-chemotherapy, and then we have castration-resistant disease that can be either pre or post-chemotherapy, and this new emerging field that I'm going to spend a few moments on called oligometastatic disease, which is really providing a tremendous amount of excitement in the overall management of advanced forms of prostate cancer. So the question for metastatic castration-sensitive prostate cancer, are triplet therapies the new standard? Previously, high-risk disease required ADT and docetaxel that was defined as having 4 or more bony metastases, one outside the axial skeleton, and the presence of visceral disease. Doublet therapies have incorporated ADT plus either abiraterone, apalutamide, enzalutamide, darolutamide, chemotherapy we've mentioned, and now the emerging new standard is potentially triplet therapies that includes ADT plus darolutamide and docetaxel in the metastatic castration-sensitive study based upon studies from ARASENS and PEACE-1. The insights leading up to triple therapy for castration-sensitive disease was PEACE-1 that showed that ABI plus ADT plus docetaxel was better than ADT plus docetaxel. ARAMIS study showed that non-metastatic castration-resistant disease had an enjoyable and enjoyed a metastasis-free survival 2 years longer with darolutamide plus ADT versus ADT. And then ARASENS, which is triple therapy, showed a 32.5% reduction in death, mainly in patients with high-risk features with similar adverse events. Whether this applies to lower-risk patients remains to be seen. And here's the percentage of patients who survived on the ARASENS study, indicating that the addition of darolutamide to chemo and ADT improved overall survival and also decreased the rate of progression to castration-resistant disease. Safety considerations of triplet therapy seem to be very similar between the two arms, with alopecia, neutropenia, fatigue, and anemia being common in both arms. The darolutamide had a higher incidence of rash and some increased incidence of falls, fractures, some mental impairment, hypertension, flushing, and diabetes, but overall it was pretty well tolerated. So what about the future of ADT in the setting of advanced imaging? And this was a provocative study by Dr. Hussein and her colleagues. And the thoughts was, will oligometastatic disease be diagnosed more frequently, and those currently diagnosed as non-metastatic castration-sensitive disease, as well as non-metastatic castration-resistant and high-risk localized prostate cancer? And will an oligo-diagnosis, can these patients actually be cured with ADT and metastasis-directed therapy and never progress to castration-resistant disease and the need for lifelong ADT? So just a few historical comments. This is a paper that was published as part of the ASCO Educational Symposium in 2016 by Bernard and Gershman et al. And basically took some data that was emerging from the use of C11 choline improved imaging, and basically made the comment that with recent advances in imaging and mounting evidence suggests that durable control is attainable with treatment modalities targeting oligometastases, either with or without the use of systemic therapy. And what's happened since that time is this entire concept of metastasis-directed therapy has emerged and has been emerging. And the MDT can include surgical removal of oligometastatic disease in the oligometastatic de novo setting or in the oligorecurrent setting. and that's generally surgical removal of nodal disease or radiation directed to oligometastases. And from my perspective of being a student of prostate cancer for many decades, this is one of the most exciting areas of disease improvement and treatment improvement, really prompted by the ability of more precision diagnostic imaging, whether it be C11 choline or gallium-68 or polarity. And so just a few summary papers. This is a recent paper published by Deek et al. And then they reported that with long-term follow-up with the STOMP and Oriole trials, which was essentially randomizations between observation and metastasis-directed therapy, predominantly radiation therapy, without the administration of ADT or other systemic therapies, that in this remains the long-term follow-up of STOMP and Oriole with metastasis-directed therapy remains associated with improvement in progression-free survival. And they present some data with progression-free survival beyond 4 years without any systemic therapy in 15 to 20% with MDT, regardless of the mutation status. The paper goes on to identify those patients without a high-risk mutation actually do significantly better. And again, MDT without systemic therapy may be a reasonable option upfront in well-informed patients wishing to avoid the side effects of ADT. Glicksman's paper was very, very informative, basically showing that you could attain biochemical NED, although it does not equate with cure, it represents a necessary step toward it. And the striking thing about this paper was in 75% of those patients who presented with non-metastatic castration-sensitive prostate cancer, i.e. a biochemical recurrence, 75% of those patients had the demonstration of oligometastatic disease with more advanced imaging technology. This paper was just recently presented at ASTRO, the EXTEND study, essentially looking at ADT short-term plus MDT versus continuous ADT, again showing a substantial prolongation of ADT-free survival associated with the combination of short-term ADT plus MDT compared to continuous ADT alone. And finally, Dr. Andrews from the Mayo Clinic looks at MDT without ADT in patients with solitary oligo recurrent prostate cancer. And in this study, anywhere between 17 to 29% were disease-free at 3 years following oligometastatic surgical resection or radiation therapy in patients with a solitary oligometastatic focus without any systemic therapy. So in closing, I think we're entering a new paradigm for the ways in which we diagnose and manage various forms of advanced prostate cancer. And it's been very, very exciting to be part of this, the treatment programs that are emerging for our patients. Thank you very much for your attention.